Hello everyone. Today our topic for the presentation is the anatomy of pulp cavity. So before going into root canal treatment, it is very important to know the anatomy of pulp cavity properly. That is because to get a successful root canal treatment, the anatomy, the different canals which we have, everything should be known properly. So what is a root canal system? We know that within the dentine, as shown in this image, there is the pulp that is housed inside. You can see this is a red portion which is a pulp, and the entire pulp is called as a root canal system. The root canal system is divided into two important portions, pulp chamber and root canal. What is pulp chamber? As the C suggests, it is a coronal pulp. The pulp that is seen in the coronal aspect, that is just above the cervical line, is called as the pulp chamber, and the pulp that is actually seen just below the cervical line on the root is called as the root canal. So these together form the root canal system. So what are the parts of a pulp chamber? Pulp chamber consists of a roof. You can see this is the roof. This is the floor. There are certain things called as pulp horns that are accentuations of the pulp chamber into the cusp, and also there consist of orifices. These canal orifices open from the pulp chamber to that of the root canal. So these are the parts of a pulp chamber. Roof of the pulp chamber, which is covered by dentine, pulp horns that are accentuation of actually the pulp to the cuspal area, floor of the pulp chamber, and canal orifice. Canal orifice is where the pulp chamber open into the lower root or root canal. So this is one of the question that was asked. The coronal pulp have how many surface? It is 6 surface. As we said, roof, it consists of a floor, it consists of mesial side, distal side. Don't forget about the buccal side and also the lingual side. So never say that it is 4 surfaces, it contains 6 surfaces. Okay, now talking about the anatomy of apical root. So the root apex was actually explained by Cutler in his study. It have 3 important portions. This is actually called as the apical constriction. Now you can see the pulp is coming and it is constricting to a particular area. That is called as apical constriction, or it is also called as minor apical foramen. Minor means smaller apical foramen. Afterwards, it come outside and it open to a larger apical foramen. It is otherwise called as major apical diameter, major apical foramen, or the normal apical foramen. So these are the 2 important openings. After that, there is something called a cemento-dentinal junction. We know that cementum is the portion that covers the root. So this is the cementum, right? And you know inside this is the dentine. The cementum and dentine comes and join at a particular area. This is called a cemento-dentinal junction. So these 3 are the important structure that we need to memorize while talking about the anatomy of apical root. Apical constriction, that is a smaller area, it comes out as apical foramen, and the area where the outer cementum comes and joined with the dentine is called as the cemento-dentinal junction. Talking about apical constriction, as I said earlier, apical constriction is the smallest diameter. Normally, it is seen 0.5 to 1.5 distance from the outer surface of the tooth. When we consider the outer surface, this will be 0.5 to 1.5 inside the apical foramen, that is from the major opening. Next important thing is like this is the area where we need to actually end our root canal. When we do a root canal, the final step is obturation, where we will be filling the canal with gutta percha. This is the area where we need to terminate the preparation and terminate the restoration of a root canal therapy, right? Next, this was one of the question again asked for your NEET PG, that is apical constriction is otherwise called as, we know that it is a constriction area. Think it is constriction, so it is called as minor diameter. If it is actually apical foramen means it is a major diameter, right? Next is apical foramen. As I said, apical foramen is actually the major apical diameter. This is called as actually apical foramen. Important thing is like it is having either a rounded edge with a funnel-like structure, or it is having a crater-like structure. So it is very important. Either it will be a rounded edge with a funnel or crater-like structure. And very important thing, as you can see in this image itself, it is not particular that a pulp should always end at the correct center of the root canal. Right. It is never mandatory that the apical foramen that move to the outward portion of the periodontium should not end at the center of the root. It can be eccentric, that is away from the center. Most of the cases it is eccentric. This is the apex. When we see the apex in radiograph, it is called as radiographic apex. Okay, and they are saying that most of the case it is 0.4 to 0.7 mm away from the anatomic apex. Anatomic apex means, this is the anatomic apex, the actual end of a root is called as anatomic apex. From there, the opening will be about 0.4 to 0.7 mm away. I hope you understood. So this is actually the opening distance. It is never center. It can be away from the actual anatomic root. Understood. Next is the space between the major and minor diameter is actually, this is the major and minor diameter. It is having a funnel structure or a hyperbolic structure. So it is in the shape of a morning glory flower. You know, a morning glory flower which is in the similar way, a funnel shaped structure. It is having similar structure. So the space between major foramen and minor foramen is having a shape of a morning glory flower. Right. Normally, as I said earlier, so this will be the constriction area. This will be the constriction area, and they will actually open like this, right? And normally the distance between these two, major foramen and minor foramen, is 0.5 mm for a young individual, and it is 0.67 in an older individual. As you can see, older the patient, the distance between the major and diameter and minor diameter is increasing. Why? Why? Because as the age increases, because of our continuous usage of our teeth, etc., there is deposition of the cementum, etc., in this area, and there will be enlarged space between the major foramen as well as the minor foramen. So that is why. So these are the things that you have to keep in mind. First is the diameter of the major not diameter, you need to actually memorize the distance of the apical constriction from the outer surface. Similarly, you have to think the distance of the opening from the anatomic apex, and what is the distance of the major foramen and the minor foramen. It increases as the age increases because of the deposition of materials over time. Next, very important term is anatomic apex and radiographic apex. What is these? You can see in this image, there is ending of this root here, right? You can see in radiograph, when we see an apex, the ending of the apex in radiographic analysis, it is called as radiographic apex. And similarly, when we see this tooth anatomically, it is called, when we extract the tooth, we will see the end of the tooth, right? That is called as anatomic apex. In this image, I hope you people will actually like find which is the anatomic apex. This will be the anatomic apex. Is the apical foramen at the center? No, it should. We think that it should open at the center. No, it is eccentrically placed. See, it is away from the anatomic apex. It is away and eccentrically placed away from the anatomic apex. You can see. So never the apical foramen is at the center of the root. Understood? Next important thing is furcation canal or accessory canal. What are furcation canals or accessory canals? As I said, the root consists of a root canal. So this is actually the root canal. See, this is the main root canal which opens outside. So this is never the single canal that is present in a tooth. There are bifurcations and trifurcations. There are small accessory or extra canals that branches from the main canal. See, this is the main canal and it is actually branching outward. So that is actually called as the accessory canal. Accessory canal are extra canals that branches from the main canal. Now, what is percussion canal? As the name suggests, there are canals which are seen on the percussion area or open into the percussion area. Those are called as the percussion canals. So these are actually extra extension from the main canal, and you can see like some question are like the quantity or the percentage of foramen, that is accessory canals, is seen in which part of the root. So is it apical part? Is it middle third? Is it the cervical area? It is apical part. Very important. 73.5% of the cases, the accessory canals are actually seen in the bottom or the apical area of the tooth, as you can see in this image. See, it is mostly seen in actually the apical area. So that will be the question sometimes. Apical area constitute large amount of actually the accessory or actually the lateral canals. Okay, that is why when we do periapical surgery, we used to do episectomy. When we do episectomy, we cut 3 mm of the root apex. Why? Why? Because that is the area where it consists of large amount of accessory canals and lateral canals like this. Very, very small canals will be there, and it is really difficult to remove the microorganisms that is present in this very small lateral canals. That is why we have to do when we do a episectomy, we have to cut that 3 mm, because that 3 mm consists of large amount of accessory canals and also lateral canals. So whenever you study this, you have to memorize first apical area consists of large amount of accessory canals. How many millimeter? 3 millimeter of the root apex consists of the most lateral canals and accessory canals. Next question is like, whether this lateral canals and accessory canals consist of pulp. We know that the main canal contain pulp, right? Whether this lateral canals have pulp, that is my question. Actually talking, the lateral canals also have blood supply in that. But for example, if the main canal supply is dropped or necrotized, the lateral canals does not form a collateral supply. They does not form a collateral supply. In certain cases, like in a heart and all, like if there is a single opening, if it get blocked, there will be some other way through which the blood is actually coming to the particular area, right? That is not possible in our tooth. If the main canal is the main thing which actually supplies the blood to the tooth. The lateral canals, which consist of the pulp in that, cannot form a collateral supply to the particular tooth, right? As I said, lateral canals are accessory canals that branch from the main canal. And what is accessory foramen? As you can see in this image, the canal is actually opening outward, and there is a small opening that is called as actually the accessory foramen. Accessory canals open out to form the accessory foramen. Don't get confused. The other is apical foramen, right? So next question is, among anterior tooth, which tooth have the most number of accessory canals? So the mandibular central incisor is actually the tooth in which most amount of the accessory canals have been found. And in the case of posterior teeth, accessory canals are mainly seen in the mandibular first molar. Okay, that especially in the percussion area. Okay, it is in the percussion area, right? Next question is, accessory canals are frequently found in, so again the question, cervical 1/3, middle 1/3 or apical 1/3. As I said earlier, apical 1/3, that is 3 mm of the root apex contain maximum number of the accessory canals. Next topic is isthmus. What is isthmus? As I said earlier, normally we actually see the root like this. Right, we usually see the root separately. But some cases, because of the fusion of Herdwig's epithelial root sheath, that is during the root formation, this two root canal fuses together and there it forms a C-shaped cavity. I mean, you can see in this image, there is actually a C-shaped canal configuration by the joining of the two roots. You can see in this image there is actually joining of two root which is giving a C-shaped cavity on the occlusal surface. So It is a narrow ribbon shaped communication. You can see it is a very narrow and it is having a ribbon shaped communication between the two root, and it is mainly happening during the fusion of the Herwing's epithelial root sheath during the root canal formation. And it was found that the percentage of occurrence of isthmus increases continuously from every 1 mm from the apex. So that is a first 4 mm. That is, the C shape might not be that much visible on the coronal aspect. But as we come from the apical area towards the upper area, the first 4 mm often show the canal C-shaped or C-shaped isthmus configuration. That is, the narrow ribbon-like connection is often being shown. Now, isthmus is actually divided into three important classification. See, the two root is connected by a incomplete, very faint communication between the two canal. Next, again, characterized by two important canal, but they are having a very definite connection between the two, very definite narrow connection. And the third is like the other was long, this is small, very short communication between the two canal. So isthmus is actually the connection between two roots, and normally it might have an ovoid or like a ribbon shaped structure. When we actually view, it is of three type: incomplete, larger, definite, smaller, ill-defined. So next is like complete or incomplete isthmus between three canals. Till type 3 there was two canal joining. From type 4, it is three canal joining taking place. You can see a ribbon-like connection that is maybe complete or incomplete, connecting two or three canals. Last is type 5, marked by two or three incomplete without proper visible connection. That is the type 5 isthmus connection. Hope you understood. First, definite, but it is incomplete. Second, larger, shorter, multiple canals, and incomplete. Just try to memorize the image. That helps you, rather than like keeping on reading things. Try to actually memorize the images, which makes it easy for replicating in your exams. Okay, next is C-shaped canal. You can see in that image, there is normally the root canals are that separately placed. Sometimes it is a variation of the root canal morphology where there is fusion of the roots taking place in the buccolingual direction, which gives them a C-shaped canal. And very important, C, memorize it. This was first explained by Koch and Cox in 1979. So it is C-shaped canal, which is a variation of root canal morphology by the joining of the buccal and the mesial and the distal root, or either the buccal and lingual root surface. And the classification is like Melton was the one who gave the classification for C-shaped canal. Please don't get confused by C-shaped and isthmus, right? Isthmus, just memorize the 5 classification. Melton in 1991 gave the classification of C-shaped canal. See, you can see in this image, it is continuous C, then it have a semicolon appearance, then 2 discrete or 3 discrete separate canal. Joining, separate, or a semicolon appearance, discrete canals. This is the question that you need to actually memorize when you study for NEET PG. What is the higher incidence of root fusion and in which tooth contains C-shaped canal? First is mandibular second molar is the most common tooth in which this is seen, which is followed by the mandibular first molar, then the mandibular third molar. Then the maxillary second molar, maxillary first molar, maxillary third molar. And least is actually seen in maxillary lateral incisor. So if a question is asked, among the anterior tooth, which tooth have the most common chance of a C-shaped canal is like maxillary lateral incisor. Please don't forget. So answer accordingly. Posterior teeth means mandibular second molar. Anterior teeth means maxillary lateral incisor. Next is root canal curvature. A tooth is never straight. It consists of a curvature at the apical area. Grossman told that a tooth with a straight root canal or root is a misconception. it is not, there is no such concept that a tooth is straight. It always have a curvature. So Snyder was a person who gave a basic classification for root canal curvature, and this is the numbering. Sometimes it will be slightly curved, that is called a straight, that is 5 degree or less than 5 degree curvature is there. Moderately curved, which contain 10 to 20 degree curvature is there. Severely curved, 25 to 70 degree uh, curvature is there. So this is also very important. You have to keep in mind what are the classification of root canal curvature is there. So we talked about different root canal, what are the parts, etc. Now my next question is like, is there only one canal present in a root? No, there are lot of different configuration that is seen in a root. See, this is a single root. We might, when we extract a tooth, we might see the root like this. But the canals within that is one? No, it have various configuration. So certain people or certain scientists gave classification for these root canals. First was given by Wayne. See, Wayne have given type 1, which contain a single canal. You can memorize it as 1. Second, 2 is like 2 1 pattern. It is moving as 2 and it is coming out as a single canal and a single orifice. See the third one, 2 coming out as 2. 2, 2. Right. Next is the single canal that is actually coming out as 2. 1, 2. So memorize like this. Wayne's classification is 1, 2, 1, 2, 2, 1, 2. Next is Vertosi's classification. This is also very important. Single canal coming as single, 1. Next you can see 2 canal coming and joining as 1, 2, 1. 3 canal, I mean again third type 3 means 1 canal coming splitting into 2, it forms 1. So 1, 2, 1. Type 4 is like 2. 2 coming and joining as 2. Very easy to memorize. It is alternative numbers. 1, 2, 1, 2. Memorize like that. 1, 2, 1, 1, 2, 1, 2. Next is, you can see again 1, 2. 2 coming, joining as 1, moving out as 2. Then 1, 2, 1, 2, 3. So this is the basic classification of Vertosi's root canal anatomy. It is very easy. You can see the starting numbers are alternative and just memorize the image. By that you can actually study the variation in root canal. This is very important. Sometimes the question may be asking like, what is the type 3 Vertosi's classification for root canal anatomy? So this is also another important thing regarding the anatomy of tooth. So talking about the anatomy of tooth, you need to study the various parts, especially emphasize on the Cutler's study where he studied about the apical constriction, major foramen, minor foramen, cemento-dentinal junction, and the small values that you need to keep in mind, the shape of the funnel, and again the root canal anatomy, the root canal different configuration, C factor and isthmus. These are the important topics that you need to cover when you study on the anatomy of root canal. So hope you had a good like informative class. We'll see you on the next class. Thank you.